webinar on, okay. Okay, we're recording now. I'm so excited to say good morning to you and thank you for joining us for this webinar on the sliding fee scale, hosted by the Wyoming Primary Care Association and Joe Rivera with Q&E Services. I think that you'll enjoy the time here. I appreciate you making time to join us. And without further ado, I'll turn it over to Joe to introduce our presenter this morning. Take it away, Joe.
Thank you very much, Jan. I appreciate that. And so we're going to be listening to a webinar, or experiencing a webinar here given by Karen White. Karen White is an OSV reviewer. She has many years experience with compliance and specializes in the sliding scale program. So we are so excited to have her with us today and to provide this information. We're going to be talking about some compliance issues and also how to use sliding scale too to educate and help others learn about other programs that they may be eligible for. So without further ado, we're going to give our attention now to Karen White. Karen, I'll let you introduce yourself and talk a little bit about yourself before you begin. So thank you very much. And again, we welcome Karen White as our presenter.
Thank you, Joe. Thank you, Jan. I'm very excited to be here today. I've been working with community health centers now for over 21 years, first as the CFO of a health center. I have been doing operational site visits, technical assistant visits for over 10 years now. I've been to almost 400 health centers across the country. So perhaps I've been to your health center at one point in time, or definitely been in the state because I've been in all 50 states now. I also do UDS reviews. And so anything that has to do with the community health center, I've been involved. I'm currently working with a large health district that has a community health center attached. So I've been to very rural, as in the middle of, literally the middle of nowhere in Alaska, to very large urban sites in Chicago and New York City, et cetera. So a lot of experience with different health centers and different sizes. So the agenda today, again, probably more than what you want to know about the sliding fee program, how to navigate the virtual OSV, and then tips from a reviewer and best practices and pitfalls. And I'll kind of sprinkle those throughout the process. So you'll be able to hear them as it is relevant to the slide or the topic that we're talking about. And then I'll answer some questions, and then I'll turn it over to Joe, and he'll talk about the sliding fee scale and how to educate and assess, enroll your patients in other healthcare programs, which is a requirement, as you know, under the protocol. So just a quick question to get everybody thinking. Everybody knows jelly beans. Everybody's heard of jelly bellies. So what do you call a jelly bean who doesn't meet quality standards in the Jelly Belly Corporation? Does anybody know that answer? Actually, I think one of their factories is in San Francisco. No chats? Okay, so I'll give you the answer. A jelly bean who doesn't meet quality standards is called a belly flop. We don't want this to be a belly flop, and we certainly don't want your OSV to be a belly flop. Okay, so the concept of sliding fee, I think we can all agree, is it's really simple. But why is it so complicated to operationalize? So the sliding fee program, some of the must-haves. So again, you have to offer it to all patients. You have to have a policy that designate who you're going to offer to and how it's going to be done. It needs to be uniformly applicable to all patients. And that word uniformly, best practice would say that in your sliding fee policy, you'll say that it's uniformly applicable to all patients. You can have multiple sliding fee scales for your different lines of service. And you have to have procedures to assess and reassess. And then, of course, you have implementing sliding fee screening and enrollment process. So again, must be offered to all patients for all scope of services, regardless of the mode of delivery. So you have to make it whether you offer it on site, whether you offer it via a contract or agreement, or whether you refer out. There has to be a sliding fee element to all of the required services. And must it be offered to insured patients? Yes. So as part of the policy, we need to define income and family size. And the Bureau gives you a wide berth as far as what your definition is. The only thing they require is that you do have a definition in your policy. So keep in mind, we're talking about what needs to be in your policy and not in procedure. The protocol says sliding fee policy. So you want to make sure that all of this required language is in the policy itself. So your definition of family, it could be based on the IRS form on your 1040, who can be claimed as a dependent. It could be everybody in your household. What about adult children? Are they, that's in college? Are they included in your family or are they not? What about extended family? What if you have a health center patient that their parents or their aunt and uncle or somebody lives with them? Are they counted as family? What about grandparents? Do you use the federal definition? Do you count usually family members? Do you count them by birth, by adoption? What about partners? What about foster children? What about adults living in the house that are not related? So all those things that you need to determine in your definition of family. And you can say, this is what's included in the family, and then this is what's excluded. And again, the definition is yours. What about income? So you need to define income as well, even though it seems pretty obvious. Again, it's a requirement. So is it all cash receipts before taxes? Is there anything excluded, excuse me? Do you exclude, like school lunches, WIC, rent assistance, student loans, things like that? And then what is proof of income? So proof of income is different than the definition of income. So proof of income is, what do I need to bring in as a patient so that I can complete the sliding fee application, so that I can get my services slid if I qualify. So obviously proof is a laundry list of things that you can accept from your W-2, from your, if a person is self-employed, they could use the self-employment form from the 1040 tax return. It could be social security letter, pension letter, check stubs. It's a laundry list of all of the different things that you can include in your what's called in your proof of income. And if you have check stubs, then you want to you need to determine how many check stubs they will need. Is it for a month? Is it for 2 weeks? What you would require. So keep in mind that when you're doing both of these, you don't want it to become a barrier to care. So you don't want to say, for instance, I went to one health center once and they required 3 months of check stubs. Well, that's a barrier to care for most people, because most people don't keep all of their check stubs, and not everybody has the capability of going out to a company website and getting those. So keep in mind what you accept and whether or not it would be considered a barrier to care or not. And also, do you accept self-declaration forms? And if so, what are the parameters for that? Obviously, most health centers will accept them, but you don't want to get a self-declaration for every person, because then that means you're not doing your due diligence to try to determine what their income is. So again, you want to assess all patients, not just the uninsured patients. Everybody is eligible to apply for a sliding fee discount. You need to discuss in your policy the manner in which the health center sliding fee discount schedule is structured. So for instance, you literally have to say that the nominal fee for medical is X and the nominal fee for behavioral health is Y, nominal fee for dental is Z, and then whatever services that you might offer. And then you also need to, in a narrative form, describe your sliding fee scale. So it doesn't have to be the actual federal public guidelines, because that limits your policy's life, but you can say 100% and below, they're only charged a nominal charge. Between 100% and 133%, they're charged X, and over 133 to 166, they're charged Y, and over 166 up to including 200, they're charged something else. And then show the last column, which would be over 200%. You want to say that it's full charges, no discount allowed. Nominal fee or nominal charge. So we'll talk about in general what it is, but you can have a different nominal charge for each service, as I indicated earlier. And equally important is follow your policy, because as you know, what happens on operational site visit or for any visit, your audit will do the same thing. They will look at your policy and read it, and then they will do samples to make sure that you're following your policy. So this information or your policy is important not only for the visit, but also for your audit. So just the parameters of the sliding fee scale, obviously a full discount for 100% and below a federal poverty guidelines, and you can only charge, you can only assess a nominal charge. And then a partial discount for patients whose income is over 100 but equal to and less than 200%. So and then no discount over 200% of federal public guidelines. So what I know a lot of health centers, they want to offer a discount over 200%, especially to the uninsured patients. So under the federal program, you cannot offer a discount, a sliding fee discount over 200%. However, if you have another pot of money, say you have some donations or you have another grant that's unrestricted or restricted for this purpose, then you can offer a discount over 200% and utilize that grant, those grant funds. One thing to make sure you remember is if you do that, you need to code it differently in your practice management software. So under sliding fee discount, you know, it's going to be labeled sliding fee discount, but for the other grant or whatever, you don't want to use sliding discount because that would be not allowed under the program requirements. So you would have to call it something else, other discount or something like that, just so that if you, when you run a report for UDS purposes, you're only going to show the sliding fee discount, not the other discount. And also your auditors would want to know as well. And of course, site reviewers are going to ask that questions if you offer a discount. And keep in mind, other programs will allow you to discount more than 200%. I mean, family planning will go up to 250%. And the Ryan White program, it's up to and even over 400% of federal poverty guidelines. So you want to make, if you have all those additional programs, you want to make sure that that's captured in your sliding fee policy, maybe as a separate section, or at least have an additional verbiage that describes how you're going to treat the Ryan White program or a family planning program or something similar to that. And then also one of the other requirements is that you have to have 3 discount categories between a 100 and 200%. That's why I gave you the example of between 1 and 133 and through 133 to 166 and 166 to 200. That would be the 3 categories. You can have more than that. I caution you to have, if you would have more than 5, I think it gets very cumbersome. I've gone to some health centers that every 10% they have had a new sliding scale, and it's very cumbersome to try to deal with. It's hard for the front desk to keep track of it all, and then making sure that your practice management will actually do it as well. However, the only requirement is that you must have 3. You can have as many as you would like to have, as long as it's at least 3. So what is the nominal charge and how do you determine it? So you can have a different nominal charge for every service, and most health centers do. And it has to be a flat amount. It can't be determined by the cost of the service, but it can be different from each one, which I know that's kind of an oxymoron right there. Okay, so it's a flat amount. It can't be based on the cost, has to be nominal from the patient perspective. But wait a minute, how do we determine that? So there's a few ways that you can determine whether it's nominal from the patient perspective. You can speak to board members. However, it's difficult when you're at a board meeting to ask the board members how many of you are on a sliding fee discount. They would have to volunteer the information if you would ask at a board meeting. Do you hear anything from your constituents that says that, you know, the sliding fee is a burden or something like that? Phrase it in a way that you don't draw attention to anybody or make anybody feel bad because they're on the sliding fee discount. Also, you can do a patient survey. So in the past, a lot of health centers have had a patient survey and they said, are the fees reasonable for all the services provided? And that anymore is kind of old school. That's the question that a lot of people have asked, and not all reviewers will accept that. The more recent question, if you will, is that have you ever, asking the patients, have you ever canceled or no show for an appointment due to the fees and charges, your inability to pay those fees or charges? Because that will tell you if they're canceling appointments that perhaps the fees are too high. But also you would want to make sure that they understand that you would have a waiver fee policy, but we can talk about that later. And talk to your front desk. They know your patients. They can pretty much tell you, they can probably tell you at any given day who's going to no-show or who has the highest probability of no-showing. Don't underestimate the knowledge that they have at the front desk. And you can also talk to your billing department, because they will also know, they have conversations with your patients to find out what are the reasons why they're not paying their bills. So on your sliding fee scale, make sure that you use the current federal public guidelines. That is something that's checked. As you know, it comes out usually the end of January. The expectation is that you should have it updated and approved by your board, usually for effectiveness either in February or March, given when your board members meet. Most likely you're not going to get it done in February, but perhaps you can, depending on the day or the timing of it. So you can have a separate sliding fee scale for medical if you want. It can be one for, normally for medical, there's usually only one, but you can also bundle services. Like if you have an OB program, you can bundle the cost of the services for OB if you want to. Behavior health, you can, again, it can be a different flat fee for the nominal charge. It can be a different percentage or a different payment across the board. And you can also bundle if you have somebody that's scheduled to come in every day for 3 weeks or something, and you don't think they can pay that nominal fee every time, you can do a bundled service for that as well. Dental can be a little bit more complicated, but they will accept 2 different dental sliding fee scales. So one for office visits or preventative care, basically, and the other one for expanded services such as dentures, root canals, etc. And also keep in mind everything on 100% and below with federal public guidelines must be a flat amount, but you can charge the cost of the equipment. So for instance, if your nominal charge for dental is $35, they need dentures, the dentures cost you $400, then you would bill the patient $435. So you can add on the cost of the equipment for that. Again, I'm talking primarily about nominal charge. Each category of slide, will be a percentage of your charges or a flat amount, however you want to set that up. Pharmacy. So pharmacy is kind of an exclusion. And I just put in the guidance from the protocol that you guys can look at later, but you really don't have to, you can determine how you're going to charge for pharmacy. And the lab, you must offer that on a slide. If you have an agreement, which most health centers do, they have a lab core request agreement or something, then you have to make sure that there's sliding fee language on there. And then you need to figure out, how is it going to work? Is the health center going to pay for the uninsured? Are they going to pay for part of them? Does the lab give you a credit for part of them? All of that you need to make sure that you spell out. And then another question that gets asked periodically on visits, it's not always consistent, is what do you do with the patient who has labs who have insurance, but the insurance doesn't cover the labs? What do you do with them? So that's something to think about on how you want to handle those. In most cases, I've heard, we try to get the contract to cover that scenario, but most of the time the labs, core and the Quest, are not always willing to do that. But have a process in place where the patient who has a large bill for their lab can come in and talk to you and figure out a payment plan, or to reach back out to the lab company to say, hey, this person's effectively uninsured, so these should have been slid. Okay, so who can apply for the sliding fee discount? Everyone. We have to offer it to anybody who walks in who wants it. Then make sure that you have the implementing procedures for assessing and reassessing, because we will look at those. What is your process for having that done? And we will look at the application and any forms that you have. You need to inform patients. So you need to have multiple ways of informing patients. So it could be notices that are posted in the clinics, could be your website. You could have brochures that you pass out to patients. And then the registration desk should query patients if they're not insured for sure about not only the sliding fee scale, but also as an opportunity to refer them to eligibility to see if there's other programs that will pay for their visits. Because clearly, you know, the worst payer for a community health center is the self-pay insurance, you know, self-pay patient. So, and Medicaid, of course, is our best payer. So if you can get people enrolled in Medicaid, I know Wyoming did not expand, but there are still most children and some adults that might be covered. So just knowing the rules and then looking at the marketplace to see if there's something else available to your patients. It helps not only you, but it helps the patient as well. And patient samples. So this is, I'll say it later, but this is probably one of the ones that, surprisingly enough, I have the most issues with that as a reviewer. So first, make sure you close the loop. They're going to look at 5 to 10 records, and we need to see the cycle from beginning to end. So literally what I want to see when I come in, I want to see the application the patient filled out. I want to see their proof of income. I want to see the screen on your practice management that shows that income was entered, the family size was entered, and they match the paperwork that I have in front of me. And I also want to see that the slide that's calculated is the slide that I calculate when I look at your sliding fee scale based on income and family size. So I want to see all of that. Then I want to see a visit. And if your nominal charge is $20 and a patient comes in and they should be charged the nominal charge, then I want to see that it slides to whatever it is, the $20 or whatever your nominal charge is for that type of visit. So I want to see the whole process. And what I see a lot of times is just partial. I'll see the application, but I won't see the practice management screens. And we need to be able to see the whole thing to make sure that it's implemented correctly for your patients. And keep in mind, you guys are picking the samples. So please scrub them, make sure that they're correct before you share them with the reviewer. Sharing them with the reviewer are a couple different ways. You can take screenshots and then you can redact some of the patient information. Keep in mind when you redact it, you can't redact it so badly that we can't follow it to know what's going on, especially if you have multiple patients in one PDF, which I don't recommend. Or the other way you can do it is you can do live navigation. So your billing manager, et cetera, can have the list of accounts that they want to share and for this part of the review, and then they just walk you through the screens and show you all those items that I wanted to see, the application, proof of income, the screens that's entered, and then the visit. So make sure you pick good compliance samples. But this one shouldn't catch you up. Remember, it's an open book test. So services provided via column 2 or column 3. So this is a little bit more complicated. As you know, this is one of the ones that are oftentimes difficult because here we are as a health center, we're asking a third party to offer our patients a discount. And so we understand that sometimes is difficult to do. So for column 2 services, we're going to look at least 1, but no more than 3 contracts for each service that you required or additional that you have marked on Form 5A. So, and we will look for the same kinds of language that we already talked about that it's in column 1 services. So a nominal charge is the only thing you can charge for 100% and below, 3 discount categories between 100 and 200, and actually the over 200 part, one of the caveats is if your contract has a better discount than what you have, then that's acceptable. So, I mean, occasionally we'll see somebody that will say, we'll just give you a discount for everybody 200% and below. And so that is compliant because it's better than what your policy is. A lot of times in column 2, the services are provided at your location, in which case your own sliding fee is the one that's being utilized. But keep in mind that there needs to be some language in the contract states that patients are seen in our location, and your health center's sliding fee schedule and policy will be utilized for those patient visits. So column 3 services, those are, of course, for the referral. When the clinical person goes over Form 5A, they make sure the clinical person is usually the one who would determine which contracts we're going to look at. So if you've got 5 contracts for dental services, clinical would decide which 1 or 2 that they're going to want to look at. And then those are the ones that fiscal looks at as well. So we look at the same ones for this purpose anyway. And again, the requirement is at least 1 contract per service, whether required or additional, that's listed in column 3, up to 3, but 1 for each service that's marked. So you want to make sure that your Form 5A is correct. That's real important. And for the requirements for column 3 services, you have to make sure that there's a discount between 100 and 200% of the federal public guidelines. And for patients 100% or below, they received a full discount for those services, or just charged a nominal charge. So again, that can be very difficult. You want to keep in mind when you look at your hospital sliding fee policy, this is one that we see a lot. The hospital is more likely to say, yes, 200% or below, they're going to get a discount. It's probably going to be better than yours. However, the caveat to the hospital agreements is that they have an asset test. So what I mean by that is they will want to know the price. Do you own your house? Do you have vehicles? Do you have savings account? And as you know, for HRSA's benefit or point of view, you can't determine what they own as part of it. They can only, for HRSA, we can only determine what they make and not what they have available to them as far as assets go. So a lot of times the hospital one can be difficult because of that. So patients with third-party coverage, yes, you must offer the sliding fee to all patients, even those with third-party insurance, including Medicare. So the 20% co-insurance for Medicare could also be slid. Obviously, the caveat is if the health center, if the patient qualifies for a sliding fee discount. When you think about offering it to third-party coverage, keep in mind it's a benefit to the patient and to you. So what happens is a patient comes in, they have third-party insurance, you get the sliding fee information for them. It can be set up in 1 or 2 ways. It can be just the information's in there separately, or in some systems you can say that the sliding fee discount is a secondary payer so that it will automatically slide for you after the primary payer has either paid or not paid. But what's beneficial to the health center is you bill the insurance, and then even though the insurance doesn't pay, it starts whittling away at that deductible for the patient. And so the hopes is if the patient needs hospital or more specialty care later, their insurance might start paying. And also by the end of the year, it might start paying you as well. So it's important to have people with insurance. We want to bill for that service. One of the other caveats for patients with third party that you can't charge them any more than they would have under their applicable sliding fee discount class. Again, this is subject to any kind of legal or contractual restrictions. And it used to be you could just say, well, it's subject to I can't do that for my contract. But now we're being asked to look at that actual contract and to find that actual language that states that you cannot offer them a discount. What we have found is that when we actually start looking for that language, we don't find it very often. So the evaluation of the sliding fee program. So it has to be done at least once every 3 years. You need to collect utilization data. And the utilization data it works a couple of different ways. So we want to know how many patients are in each category of your slide. So if you look across to your categories, your 5 groups. So for example, how many patients fall in each one of those groups? How many patients are under 100% of the federal poverty guideline that are under your sliding fee program? And then think about whether or not that makes sense. So in a state that doesn't expand Medicaid, then it might make sense that it's a fairly high number because they don't qualify because the state doesn't pay adult Medicaid for the most part. But if your state did expand, then you would wonder why the numbers are so high. Do you have a high undocumented population, in which case they may not be eligible for Medicaid? But just thinking about the numbers and making sure that they make sense. And then a best practice would be to, when you look at that utilization, look at just your uninsured patients. How many times do they come into the clinic? And then look at your insured patients. How many times do they come in the clinic? So if your insured patient comes in on average twice a year, and your uninsured comes in on average of once a year, those numbers are a little too small, but then you might wonder, why are they not coming in more? Is it because that they can't afford to come in? Or is there something else going on that you'd want to know about? So that's the way you can kind of actually use the data, because otherwise knowing how many is in each category is not, in my opinion, is not particularly helpful, but it is part of the requirement. But looking a little deeper at those numbers, and then you can, on your UDS, it will tell you overall how many patients, how many times an average patient comes in the door. So you can kind of use that as a benchmark if you want to say, okay, now what about uninsured? How many times do they come in the door? And then other data, again, looking at patient satisfaction forms. We've talked about that a little bit already, as far as determining if the nominal fee is nominal from the patient perspective. You can look at collections. Are your patients paying that nominal charge? And if they're not, there's actually 2 reasons why they're not. One is because it's too high. And the second reason could be because your front desk staff or your billing, whoever it does, takes the patient payments, maybe they're not asking for that money. Maybe they're saying, do you want to pay today? Well, if you ask me if I want to pay today and I have the option to pay later, I'm probably going to say, yeah, I'll pay later. Instead, ask, how do you want to pay today? And then give the options of what you take. And again, and it's the expectation of the front desk on how you ask the question. If you expect for them to pay, then they read that in your body language. And it's really hard to be at the front desk and having to ask patients for money. It's very difficult. So kind of keep that in mind when you're talking about it. And then you can do some like role playing with the front desk. You get somebody, because people are better than others at asking for money. I think that's normal. So maybe you get somebody who's really good at asking for money, and then you have some of the other front desk staff. She will ask, so for instance, you role playing. So you've got the one person who does a pretty good job at getting money, seems to be doing better than some of the others. Then the other ones will sit back and she'll ask them for money, and then they will give her the laundry list of excuses that they've always heard. And she can help them coin phrases and responses on how to handle those questions, because it's difficult to do. So sometimes the role playing, they feel kind of silly at first, but then they get into it and they really enjoy the process. And they've all said, when I've done it with different staff, that it's been very helpful for them, because it's a safe place, and you can say, it's a good place to ask questions. So think about something like that as well. And then you need to close the gap. So were there any changes that needed to be made? And if so, then you want to show that those were made, or you can say that you've evaluated the program and no changes are needed. So this should be in some kind of a document, so that when the reviewer comes on site, you can just hand it to them. It used to be it was required to be given to the board of directors. It no longer is, but I think it's a best practice, because I think the board needs to understand how you looked at your sliding fee program and whether or not it minimizes financial barriers to care. So waiver fee. This is typically under the billing section. However, I see it a lot in the sliding fee policy. So make sure that you are required to have a waiver fee policy. It's not an option. You can't say we don't waive fees. It's not allowed. You have to have a policy. However, it's the exception and not the rule. You should not be happy. If you're using it every day, then you need to revamp that system. It should be available for use. And one of the key takeaways for that is that the waiver fee has to be available to everyone. It can't be available just to uninsured or to patients under 200% of federal poverty guidelines. It has to be offered to everybody, and your process needs to be the same. So you need to determine who is going to be able to waive, and typically you want it to be manager or above. You don't want front desk being in that awkward position where a patient is intimidating and telling them that they need a waiver fee today because they can't pay. So you want it to be higher than them so that they don't have to deal with that. They're not paid enough to deal with that. And then you need to have some examples in your policy on reasons why you might waive the fee. So it could be, you need to put 2 or 3 in. So it can be such things as house fire, just lost their job, could be a national disaster. It could be any number of things that you'd want to say, but you just need to have, 2 or 3 of them listed in your policies as examples. And then obviously it's a case-by-case basis. And clearly in the sliding fee policy and in your billing policy, it's a best practice to say that no patient will be turned away due to the inability to pay. It's something that's obviously very important to HRSA and to all of us. That's why we're doing what we're doing. So the top 4 compliance issues that I find in a virtual OSV, and actually they're very similar to the ones that I find in the OSVs that back in the day when we traveled. Your policies don't include all the required language or elements. So make sure you do that check off that it includes everything that's needed. A lot of the times I see that there's no sliding fee evaluation done at all. And when I ask about it, people are just surprised. It's like, sure, we evaluated. I said, okay, can I see the paperwork? Well, no, we talked about it and we decided we don't need to make any changes. I said, well, that's fine. That's good. But you still have to have the paperwork to follow us up on it. So make sure that you do that as well. And then contracts don't have sliding fee language. So one thing to think about contracts, if you get ready for a virtual OSV, a lot of times to make a revision of a contract, it can take months. And you don't always have that much time. You can do an addendum to that contract, which usually is done much faster. And that's a way that you can bring yourself into compliance. If for some reason you can't get the information in the contract, then just document everything you've done and all of the attempts that you've made to get the required language in your contracts. And then the 4th one is that the samples, they don't close the loop. I don't have all the documents that I need to see, or any review will have all the documents that they need to see to ensure that you're assessing patients correctly and reassessing patients correctly. As a best practice, remember that somebody should be doing audits on your sliding fee application. So taking X number of applications and do them for X number for each site, or do them by front desk if you can track them that way. And then make sure that everything matches, because if it doesn't, that gives you time to provide additional education and to make corrections on those accounts before somebody comes in and looks at them, such as an auditor or a reviewer. Are virtual OSVs different? Of course they are. When in a regular OSV, it's not uncommon to have a clinical admin or physical person come into your office and sit there and be there for quite a while, to go up to your front desk and talk to your staff, talk to eligibility staff. For an virtual OSV, that's almost impossible to do. You're going to be looking at doing it just like we're doing this webinar. The questions are asked via the webinar. It doesn't, in my opinion, it doesn't give us much opportunity to get technical assistance as they did in the past. However, the reviewers will, of course, answer your questions and provide guidance whenever they can. And the site visit protocol is moving more toward a paper review. So a lot of the information that we look at and determine whether something is compliant or not compliant is based on the paperwork that we receive. So in the old days when people used to stay in your office all day, that doesn't happen on these reviews. You may only spend a few hours during those 2.5 days on a webinar such as this, or on a call for the questions, because typically we look at all the paper and then we ask questions to make sure that we understand and that you're following what your paper says you're doing. We look at some of the samples, etc., and then that's all we have for the virtual. So it is different. The virtual tour is different. Making sure that you have somebody, in the clinic site with a cell phone or laptop or something, excuse me, a laptop, but a tablet that they can walk around and see the site. They also want to look at signage. So sometimes the physical person can't go on the tour. So they like the clinical person to say, when you walk through, can you show me the sliding fee sign? Can you show me the hour, the hours of operation, phone numbers, etc. And then everything is video conferencing. So making sure that you have video available, that you have internet with enough bandwidth to be able to have these meetings, and then the ability to be able to share screen if you need to. Sometimes we do that for policies to help us find things. Sometimes we use it to do the samples, etc. Another will be a best practice is when you're providing the information for us, please make it so that we can read it. It's not crooked, it's not upside down, it's not shaky, like I don't know what happened to it when they took the copy of it. And make the samples individual PDF files if you're going to do it that way. There's nothing we dislike more than to get all of the policies in 300 pages on a PDF that we can't search. We're all human as well, and we want to try to make it as easy as possible. Not only does it help us get through the process, but it also helps you, because if you highlight the section that addresses the question, then you can ensure that you've got all the information that you need. So that helps your review go much faster. So keys to a successful site visit. So look at the protocol. I've gone to health centers either virtually or in person, and they don't have a copy of the protocol. They've never looked at it. And then they wonder why that they have areas of noncompliance. So you definitely want to look at that protocol and upload the documents by the due date. All of us do not only private work, but they do these reviews, and some people do them almost every week. So we like to get the documents the week before so we can start looking at them so that we're ready when the visit starts on Tuesday. Remember, there's no more quick fixes. So all the documents have to be to us by the end of the first day. If you give us documents after the first day, we're not allowed to accept them or to look at them. And there's nothing that you can fix on site. So gone are the days when you have that emergency board meeting scheduled halfway through the visit so that you can get everything approved. And so there would be no findings or no compliant areas of noncompliance. But what they have now, as you probably have heard, is the review opportunity process. So what happens is the visit is over, typically Thursday at noon or so. The consultants do their report. It gets reviewed on our end. It goes to HRSA. It gets reviewed in a couple of levels of HRSA, and then it comes back to the health center. And at that point, during this compliance review opportunity or compliance resolution opportunity, you have 14 days to fix anything. So that means if you do find something during your site visit, go ahead and fix it. If it's a policy, get it ready for board approval. And then when that 14-day window opens up, then all you have to do is upload the document, show board approval if it's required. And then if HRSA accepts it, then it's like the visit, it's like the noncompliance item doesn't exist. So for instance, if you have 2 or 3 noncompliance items during their site visit and you upload all the documents during their compliance resolution opportunity, then your site visit report will show us 0 findings, that it's 100% compliant. So that's the new way that they have changed the process. And obviously you want to review all of your documents first to make sure that they're all in order. It's a group process. It's not a process that one person can get through by themselves. It's too much. So again, take times to gather and prepare the documents. And then use the naming convention. If you have anything additional that you need to upload for any reason, then do it in the proper chapter and then just name it in a way that we would know what it is. If you have a missing documents, I mean, that can impact the compliance determination. For instance, if we don't get it by the end of the first day, we're not allowed to see it. So even though you may have it, we can't look at it to determine whether that's compliant or not. Be transparent and communicate, prepare. It is what it is for the site visit, and you already know what the questions are going to be. It's an open book test. So go through them yourself for your areas of compliance and answer all the questions, look at the documents, and then that should make the visit go much faster and easier for you. Does anybody have any questions for me? So I'll look at the chat and see if there's any questions in there.
Yeah, I was just going to share with you that Dan had a question when you were talking about the evaluations. You can see it there. He said, can you tell us what OSV question addresses the utilization example that you used?
Oh, yeah, absolutely. So let me stop sharing a second. Let me pull up the protocol. I'll give you the question. So if you go to sliding, whoops, this is the compliance manual. So the evaluation, it's question 28. So it's element L. Question 28 states, does the health center collect utilization data in order to assess whether patients within each of its discount pay classes are accessing health center services?
So the rest of that, he said, using your example that the insured person comes in 3 times, but the slide patient only comes in once.
So for that would be a best practice. That would be something on the health center side that I think would be useful information for them to know. That helps them determine if the sliding fee patient only comes in once and the insured comes in 3 times, why is that? Are they not coming in because they can't pay for the service? Or is there another reason why they're not coming in?
Okay. And does that just, you can pick that up in the patient survey, or is that just a individual patient interview you would want to do?
Well, as far as how many times they come in, you'd be able to get that from your practice management, because you can run the number of, so the way they obviously do it for UDS, you take the total number of encounters divided by the total number, the total number of encounters divided by the total number of the patients, and that will tell you the average, what an average patient comes in, 2, 3, 4 times a year. You can do the same thing and just take the number of encounters for self-pay patients divided by the number of self-pay patients, and that will tell you what a self-pay patient, how many times they come in. So you can do that through your practice management when you run your reports.
Okay. Dan, did that answer your whole question there? Okay, we'll wait to hear back from him. Okay, so I think we need to throw it open for questions. Does anybody have a question to ask live at this point?
Karen,
Well,
this is,
go ahead, Joe.
I'm sorry. Karen, this is Joe. I do have a question.
Okay.
I was just wondering, the assists that are provided for sliding scale, can those be counted as part of the number of assists on UDS for outreach and enrollment? Is that something you've encountered, or a question that you've been asked?
They are counted for UDS, and so yes, you can count them. That would be counted for. You would have to probably manually do it unless you do it within your EMR.
Okay, thank you.
Mm-hmm.
Okay, there's no silly question, y'all. Please ask questions as you need. I just have one that's a general question, Karen.
Yes.
What has been the most unusual finding that you found with sliding fee?
Oh, that's a good one. Let's see. You know, I'm kind of caught off guard. I'm not sure what the most unusual one. I will think of 10 of them as soon as we're off this call.
No worries.
But I guess to me, what I always found strange is, I think I already mentioned it earlier, I will go in and I will look at the samples and they were non-compliant. And I will say this, they will look at it with me and they'll say, oh, that's not compliant, is it? No, it's not. I said, why did you give me that one? Oh, we just randomly picked that account. Okay, well, that's good for internal audit, but for compliance, you really should look at them before you give them to me. So I always find that hard to believe. I also find it, and this is not necessarily related to sliding fee, more so to billing, is that when they give me their fee schedule or even their sliding fee schedule, and it doesn't match what's in their system. And they will say, oh yeah, well, we haven't updated our system in 3 years, but we update the scale every year. Doesn't that count? No, it doesn't really count. They have to match. So that's probably the most unusual ones that I get, or that surprises me the most.
Wow. Okay. Yeah. Random versus best, right? For the
Yes,
site visit, you want to give best, even though the auditors want random.
exactly. But
That's a
by
great
doing
point.
your monthly audit, then you're going to catch them and you're going to figure out if there's an issue way before the audit comes or before the visit arrives.
Great. Okay. Anybody else?
Yes, I have a question. Can you guys hear me?
Yep.
Yes.
Yeah, this is Priyangani from Colorado, and we have gotten a couple of different guidance on this question. So we have a couple of managed care organizations, payers that are very closed, and we are not able to get contracts with them, and it's Medicaid. And some of those patients come to our clinic, and we're not contracted with that Medicaid managed care. In that circumstances, how would you have us deal with those patients?
So it's based on what your policy states. I know a lot of health centers will offer the sliding fee program to those patients since you can't contract with the payer. Also, I would suggest you reach out to your primary care association in Colorado and they can work with Medicaid, because typically, especially for Medicaid managed care, it's very difficult for them to be able to justify excluding an FQHC from their panel. But I would definitely, you'd have, especially in Colorado, I mean, there's a lot of patients. So I would go that route, allow them the sliding fee discount if that your policy allows that, your board's okay with it, but also reach out to the PCA and have them reach out to the Medicaid program.
So it's an internal policy decision and not a HRSA.
I don't know of any HRSA guidance that states that you can't do that. You have to bill insurance if they have it, but if you can't contract with it, you can't bill it because they won't let you bill as a non-par, not Medicaid anyway. The other thing that might be able to happen again is that your state Medicaid may pay for that patient because you have wraparound services, and so the MCO paid $0. So the state should pick up the rest of it as well.
Yeah, in these circumstances, the state won't. And one of the things is, Medicaid patients should not have to pay anything out of pocket. So if we put them on sliding fee, and even if our nominal charge is $5, the patient is now paying out of pocket when they can go to their, a contracted provider and don't have to pay anything out of pocket. And so then, you have to make sure that we get the patient to sign additional documentation saying that, they are willing to pay out of pocket even though they have Medicaid. So anyway, yeah, so we just wanted to see what you have seen and how other health centers are dealing with it.
Yeah, it makes it very difficult, especially if you're talking about a Medicaid program.
Yeah. Thank you.
You're welcome.
Okay, anyone else? All right, well, go ahead and if you think of something as we go along, we're just gonna, Karen, do you have any last minute things that you want to add? And then we'll have Joe present a couple of other ideas.
No, I just wanted to share that I have the 2 slides with the additional resources that these slides will be available to you that you can look at. The one for an area of noncompliance, you can look at the conditions library and go to the individual element that's non-compliant, and it will tell you what you have to do to fix it. Keep in mind, in the conditions library, it will tell you, you have 90 days to fix it. In this case, you only have till the CRO period to fix it if you want to do it during that compliance resolution opportunity, but it will tell you the documents that's required, because a lot of times that's the questions we get asked is, okay, now what do I do? How do I fix this? Because it's not always inherent to how you should fix it. So that's something that's helpful.
Okay. And my last question, Karen, going back to your comment about virtual site visits versus on-site, they're going to stay virtual this year, or is there any recommendation that they will continue to be virtual into the future?
I think they were virtual for sure through September. I think they're virtual now for sure through December. We're just going to have to watch the COVID and the Delta and see, when we can come back. My guess is that to some extent, they're going to be virtual going forward. I think there may be specific instances that we might be able to go on site, but I think that right or wrong, most people are pretty happy with the virtual visits. So I don't look for it to change, but again, that's just my opinion. I don't know that Hearst has made a final decision yet. They're talking about it, I know.
Well, we have a couple of health centers that have site visits coming up. So I'm sure they know what to expect, but going into 2022, I thought it'd be nice if we'd had a prediction. So
yeah, at this point in my projection is that it's going to be virtual into 2022, but
yeah, they put an awful lot of resources into getting to the virtual environment. So I think it makes sense that if it works, why would you go back?
Right. And plus it saves a lot of money for the
Yeah.
Bureau because there's no travel involved.
Right.
So
yeah. Okay, great. Thank you, Karen.
You're welcome.
Okay, Joe, I'm going to turn it over to you.
Thank you, Jan, and thank you, Karen. I think, Karen, your presentation really shows that just how many moving pieces there are to sliding scale, the policies and procedures of contracting, all of this that has to be done kind of behind the scenes. But in the end, in terms of access to care for patients, I think this also puts a spotlight on those who are actually doing eligibility, providing that eligibility assistance for the sliding scale program. It's a requirement. I like your points about how everybody must be offered the sliding scale program and to get a discount. The eligibility staff, those that are actually doing this eligibility and helping people to get those slides, I think is also important. I noticed that in Wyoming, there are different models, business models where it comes to sliding scale. Some health centers have staff at the front desk or intake staff who don't normally do other forms of eligibility like Marketplace or Medicaid, but they do sliding scale. And that's good, having somebody at the front end like that to provide that assistance is able to do that immediately and get them those services that they need when they need them. Also, the other model I've seen is those who do everything. So sliding scale, Medicaid eligibility, Marketplace, which is good too. So what I want to talk about today and share with the group is just a tool that's been developed that for those who are doing this eligibility at the front line, that are or intake staff, who they're really focusing just on sliding scale and not these other programs. We're going to talk about how what a best practice it really is to take it a step further though. So there are many people who are applying for sliding scale that may actually be eligible for Medicaid, Marketplace, or other programs, We certainly want to give them the opportunity, educate them, and give them the opportunity to apply for those programs too. So I'm going to just share my screen and share with the group just this document that hopefully is helpful to you. It's really tailored to Wyoming. So I know we have people from other states that are on the call, but I think a tool like this can be developed, especially if there is that model where intake staff are doing sliding scale, but not the other programs. And so again, this is a very high level view of the different programs in Wyoming that I think the majority of what Wyoming health centers encounter. Sliding fee, Wyoming Medicaid for families. It's called family care. We're going to talk about these. And what I want to do is just go through these just real quick, show how to use this tool and why it's so important. And really, and my hope is that it's just very, very simple, a very simple way of making a quick assessment of that household, that individual or the family, see if they may be eligible for some of these other programs. So there's Medicaid, Wyoming Medicaid, children's categories, Kids Care CHIP, and then the healthcare.gov marketplace in Wyoming. And so just talking a little bit about that, you'll notice the first column here is the sliding fee scale, just some basic information about the program. Sliding fee discount program is funded by HRSA. Clients pay an affordable fee for services based on their income and household size. And this is not health insurance. And I think a lot of you health centers, not just eligibility, not just intake, but maybe billing, have said, you've heard patients say, well, I already have insurance. I have that discount program. And of course, we want to put that message out there. This is not health insurance. There's an awful lot that sliding scale does not cover. For instance, if the patient goes to an emergency room and has to have various services, and they may be getting services from providers that do not offer discounts of any kind. And so sliding fee is not going to help them with that outside of the doors of your health center. It's not health insurance. In terms of lawful presence, you already know that there may be those who are undocumented or they're not perhaps Wyoming residents that are, there's no requirements on that. And this is a federal program, and anyone can have that regardless of their lawful presence status. Let's see here. I'm going to try and here we go. Federal poverty level, as Karen so well put it, is at 200% or below. That 200% is the cutoff. And so we have some examples here of a family size of 2, 2904, family size of 3, 3660. So as you're making this assessment for these patients, if you see they're below 200% of the federal poverty level, that gives you an idea that there are other programs that they indeed may be eligible for. So we take a look, for instance, at the Wyoming Medicaid family or family care program. That is for caretaker relatives or parents. The income for that is very low. That's 49% of the federal poverty level in Wyoming. So that equates to 737 for a family size of 2, 873 household of 3. So if you're assessing a patient for sliding scale, their families, they have a child in the household under the age of 18, and they're making below these standards, and they do not have Medicaid, then it would be, be a best practice to either help them, assist them to apply if you do that. If you don't, make that referral to somebody in your health center that can provide additional information on that particular program and help them to apply for that. Another one is the Wyoming Medicaid children's category. So there are two pieces to this: ages 0 to 5, it's 154% of the federal poverty level, or $2,236 a month for a household size of 2. And then ages 6 through 18 at 133%, or $1,931 per month. So again, these are federal poverty levels well below the 200%. So as you're making that assessment and you see a family that is with children that is well below the 200% federal poverty level, again, another opportunity to make that referral or to provide that assistance on the spot. So those who are doing eligibility are in a very, very positive position to do that. And it not only opens up doors to additional access to care for your patients, but it also contributes to the financial stability of the health center by having a payer class other than self-pay or sliding scale. And obviously, too, again, as I mentioned, opens the doors for access to care for services outside the health center that they might need by having Medicaid or other health insurance programs. The Kids Care chip is the federal poverty level is exactly like sliding scale. It's 200% or below. For family size, it's still $2,900 for a household of 2, $36 for a household of 3. Now, the definition of a household, though, may be just a little bit different than your definition for sliding scale, and that's okay. If you're just doing sliding scale, you have an idea of how many people are in a household based on the family size, then make that referral. Send that patient to the staff in your health center who are providing Medicaid or CHIP eligibility assistance. And so we really encourage you to do that. This whole discussion here in terms of what I'm presenting is really just an opportunity for you not to miss any of those opportunities, just to avoid those missed opportunities to help those families and children, individuals and children, to apply for one of these other programs. It really does make a difference in the lives of those patients. It's a profound impact in their lives by having access to care, especially when it comes to health insurance that's going to cover services beyond the doors of your health center. The last one is on the health center, healthcare.gov. I'm not sure if you can see that, but I'm going to try. Yeah, here we go. I'll just move that over. Healthcare.gov. It's amazing what opportunities now exist for those who do not qualify for Medicaid. If they don't qualify for Medicaid because they have not been a legal permanent resident for more than 5 years, or their income is beyond the Medicaid standard, there's a minimum cutoff for income. That's those who are making a minimum of 100% of the federal poverty level, all the way to beyond the 400% that it used to be. And so for a family size of 100% is $12,880 a month. Family of 2, $17,420. So anybody making that amount or more is potentially eligible for a tax credit to get assistance to apply for and purchase health insurance on the marketplace. And so again, anybody, in fact, since you're doing sliding scale, anybody below 200% of the federal poverty level, they are going to get a very, very attractive program that they're eligible for. The tax credits available at that income level are such that they will pay very little, if anything, in premiums, in the way of premiums for that health insurance. That's an opportunity we really want to give our health center patients because, again, it opens up doors to access for other services that they may need outside your health center. So these are just some examples. I don't want to go too far into the weeds on healthcare.gov. I know I have a lot of information here for your staff who are doing sliding scale, and they're doing that at the front desk, or they're doing this as intake staff. The idea here is not to know everything about these programs. You really don't need to know everything. But as you're making those referrals to those folks that do, they know what all the ins and outs are of these particular programs. You don't need to know, but if they meet some of these basic guidelines, then we certainly want to encourage you, strongly encourage you to educate them about these programs and then make that referral to them. I noticed that there is a question in the chat. So Marketplace, when does the next open enrollment period start? Okay, good question. That's going to be November 1st. And they're talking about extending that open enrollment to beyond the December 15th in many states where there's just a federal facing marketplace. And so thank you for asking that question. The special enrollment period that was going on during the spring and summer is over. That ended August 15th. And so now there's no ability to apply for tax credits unless you have a life change event that opens up a special enrollment period. So it's a good opportunity to talk about that. If you're helping somebody with sliding scale who has become unemployed and and lost their health insurance, that opens up a special enrollment period for them, and they can apply for tax credits. So if you find that out, if somebody comes to you and says, "Hey, I just lost my job. I don't have any money. I need to see a doctor," then again, I'll opening up those doors to Medicaid if they have children, or to the marketplace. Please do refer them to whoever it is in your health center who is providing that assistance. If there's nobody in your health center, there are those in the community. Enroll Wyoming, that is another option. Didn't provide a whole lot of information about that today, but we can get that to you if you're in Wyoming. That can provide that assistance if there's not somebody in your health center that is certified to provide that kind of help. So, but the whole idea here is to really make that assessment with a view of not just providing sliding scale services, sliding scale eligibility, but any other programs that they may be available, that might be available to them. And I'm very happy in my work with the Primary Care Association and with Jan, very happy to work with your health centers directly to talk about some ways of having those conversations with your patients, if that's something that's a little uncomfortable for you, or if you have patients who just refuse, if they appear to be eligible for Medicaid or health insurance through the marketplace, they have the right to refuse, and they're still eligible for sliding scale. But we don't want to lead with that. We certainly don't want to let them know, well, you have this option, unless they bring it up or they're really adamant about not applying. If they are, and you'd like some help with messaging those folks who are hesitant to apply for Medicaid or for marketplace insurance, then I certainly would. I'm happy to help in having those conversations. There's even a disclosure form that can be developed with some bullet points so that they understand that sliding scale is not insurance. They also understand that they are potentially eligible for Medicaid, and this is what Medicaid covers, blah blah blah, and then have them sign it. I've seen health centers do that, and have the patient sign it, and then have that on file. Then they can't come back later on and say, well, I needed Medicaid and you never told me I was eligible for Medicaid. I didn't know I could get Medicaid. But having that in your file. So if that's something you're interested in doing, it might seem a little bit over the top to some, but that is a way of just having that conversation and not doing just passive sliding scale enrollment, but really having that serious conversation with them about other programs that they may be eligible. Jan, I noticed there's some other questions in the chat.
Oh, no, I think those are just about the wanting to make sure that everybody takes a minute to do the evaluation. And so there's a link there if everybody would fill that out. I want to go back to something you said, Joe, if I could, about the fact that in Wyoming, the marketplace plans, we know some people that are getting $5 and $10 marketplace plans with the new support that they're getting this year. So that's huge for health center patients who can then get the full range of insurance options with a very small amount of money to pay for that coverage. So I think that's important. I had another point and I lost it, but I think all of these words, I know what it was. Going back to what you said, Joe, about that everybody doesn't have to be an expert. I think that's true, but I do think that if we've done anything today, we've put in front of folks the idea that you know who to call. Because even, in your day-to-day work, this isn't something that you come across all the time, but at least then you have information about who to call and the links from Karen's presentation, how to go do a little research on your own as well. So I think that those are important points to make as well. I really appreciate everybody sticking with us. And Joe, I don't know if you're finished, if we want to leave an opening for final remarks, and then we'll sign off. So I'll leave it up to Karen or to Joe to make a few final remarks, and then we'll go from there.
Thank you so much, Jan. I did have one more point I did want to make, and you reminded me of that. And that is, though, at 200% of the federal poverty level, not only are they going to get, will patients be eligible for a very low premium plan, also If they pick a silver plan that has a smaller deductible, many of them will qualify for a cost sharing reduction. That means their deductibles are reduced, as well as their other out-of-pocket, like co-payments and things like that. So that reduces our co-payments tremendously. It is not, the problem some people have with health insurance, especially in the marketplace, is that the deductibles are too high. And for some folks, that is the case when it comes to, at the higher income levels, they can only afford a plan that has a higher deductible. In this case, at 200% or below, you're looking at a lot more help with those deductibles and co-payments and co-insurance that they would have to pay. So it's going to benefit the health centers too, in terms of billing and collecting on those programs. So that's all I had to say. Thank you so much. If you have any questions, please put them in the chat, and then I'll turn it back over to Karen too. If you have any closing comments.
Great. Thank you, Joe. That's great information. I just want to have a couple of final thoughts. One thing, there were a few questions about evaluation of the program. And yes, it's required. Another way you can look at the evaluation, if you're looking, as I told you, you're going to look at number of patients in each category and whether or not they make sense or not. Keep in mind that your categories do not have to be equal. So for instance, if you do a deeper dive and you say, wow, we have a lot of people in category 2 or category B, and I don't understand why we have that, you may find that most of your patients are at 135% of poverty guidelines. You can make your second category go up to 135 if that's where your patients are at. You don't have to make them equal. Each category does not have to be equal. So you have the prerogative to make those however you want them to be. Keep in mind, if you make the change in it, you're still probably not going to collect any more money because the people in that next category are probably not paying because they can't afford to. But when you do a sliding fee discount, you're showing to HRSA and actually potentially other funders on how much free care that you're providing. So if you have a grant of $1 million, but you're providing free care based on your sliding fee discount of $2 million, then you can show other funders that here we are a federally qualified health center. Yes, we do get a grant, but we have $1 million of unfunded free care that we're providing to the patients, in this state. So sometimes it's a leverage point that you can use to get grant funds to help you take care of some of the patients who are not covered or that aren't covered by the grant. So just something else to kind of keep in mind when you're doing the evaluation. But other than that, I want to thank you very much for your time today. I really appreciate you guys. And I know that the work that you're doing is so vital, and it's not easy. So thank you so much for all that you've been doing and making it through. I guess I can only say so far through COVID. So good luck, everyone.
Thanks, Karen. Thanks, everyone. I think this concludes our webinar today, and we will love to see your comments and responses in the evaluation. Have a great Monday, everyone.
Thank you. You too.
Bye.
Bye.
Thank you.